Hello everyone. So once again, I welcome to you all to our GIT Pediatrics question answer discussion. So one of the major topic of essay question is about the gastroesophageal reflux disease. It is the clinical manifestations, then about the etiology, clinical manifestations, and the investigation management of the gastroesophageal reflux is a important question in the GIT chapter. So first, so let's start our discussion on the gastroesophageal reflux disease. So, before going to this actual discussion, we have to learn about some terminologies regarding the gastroesophageal reflux disease. That is, gastroesophageal reflux, not a disease. Gastroesophageal reflux, it is the involuntary passage of gastric contents into the esophagus. That is, usually there will be forward movement of gastric contents into the esophagus, but uh, instead of that, there will be an involuntary passage of back passage of gastric contents into the esophagus. That is called the gastroesophageal reflux. That is often physiological condition. But if there is any symptoms or complications associated with this gastroesophageal reflux, it is termed as pathological. That is, because of some pathological gastroesophageal reflux, there will be any symptoms or complication arises. That is known as the gastroesophageal reflux disease. So it is often pathological. That is a pathological condition, not like that of gastroesophageal reflux. That is a physiological. But the gastroesophageal reflux disease is due to the symptoms or complications associated with the pathological. Gastroesophageal reflux is always a pathological condition. And also another terms are vomiting. That is vomiting, which means the forceful expulsion of gastric contents through the mouth. Uh, that is, there will be intense muscular activity of the respiratory and abdominal muscles will be there. And the regurgitation, which means there will be passive, effortless the regurgitation, and it involves no muscular activity. That is, regurgitation means that is passive, effortless expulsion of gastric contents, but it involves no muscular activity. So these are the four terms regarding this gastroesophageal reflux disease. But important one is the gastroesophageal reflux disease. That is symptoms and signs or complication associated with the pathological gastroesophageal reflux, and is always pathological. So about the prevalence, the gastroesophageal reflux disease, it is about happens in about 1 to 8% of infants, but gastroesophageal reflux is very common at the infancy. And 80 to 85% of GERD happens in the preterm babies, and it decreases to 20% by the 6 months. And gastroesophageal reflux is 50 to 50% in the 1 to 6 months of age, and 15% in the 7 to 12 months of age. So it is a physiological phenomenon and it is a pathological phenomenon. Then about the pathogenesis of the gastroesophageal reflux disease, usually the backflow or the involuntary passage of this gastric contents to the esophagus is prevented by the closure of the lower esophageal sphincter. So if there is any defect, or if there is any damage or happens in the for the lower esophageal sphincter, or if there is transient relaxation of the lower esophageal sphincter, that results in the backflow of gastric contents in the esophagus. So the causes are the transient lower esophageal sphincter relaxation in the absence of esophageal peristalsis, mediated primarily through the vagal pathways by the brainstem. There will be regurgitation of the contents. That is, contents are the gastric secretions, saliva, biliary, the pancreatic secretions, and especially there will be nocturnal reflux will be there in the case of preterms. That is known as the gastroesophageal reflux. That is because of the any defect in the case of lower esophageal sphincter relaxation that results in the backflow or the involuntary passage of gastric contents back into the esophagus. So that is the pathophysiology or the pathogenesis of the gastroesophageal reflux disease. And the symptoms and manifestations are, that is, the next heading is of the essay of the gastroesophageal reflux is the symptoms, that is clinical manifestations. The red flags towards gastroesophageal reflux disease are forceful vomiting, presence of bile or blood in the vomiting, and irritability, other GI symptoms associated neurological disease in prematurity. These are the red flags towards GERD suspicion. Then some degree of the reflex is normal in the first year of life. That is called the happy spitters. Then the predisposing condition for the severe GERD are the obesity, cerebral palsy, myopathies, Down syndrome, repaired tracheoesophageal fistula or esophageal atresia, chronic lung disease or asthma, There is 30% severe asthmatic have the gastroesophageal reflux disease, then cystic fibrosis, significant prematurity, and family history of GID. These are the factors which predisposing to severe GID. Then what are the common symptoms of the gastroesophageal reflux disease? Uh, in the infants, the general symptoms are the poor weight gain and irritability. And in the children, we have the regurgitation and general symptom. And in the GIT, the symptoms like GIT symptoms of the GRD is like dysphagia and vomiting in the case of infants. And the children, there will be heartburn because of this acidic contents uh, spits out through this esophagus into the mouth. There will be heartburn, retrosternal chest pain, and the postprandial fullness is there. So these are the GIT symptoms in the children due to GRD. And the respiratory symptoms, because of this involuntary backflow of this gastric content, there will be chance for the aspiration. So the infants, they will have the respiratory symptoms like recurrent pneumonia because of this aspiration pneumonia, and the asthma or the recurrent wheeze will be there, and apnea or the apparent life-threatening illness will be there. And the case of children, there will be respiratory symptoms like chronic cough, asthma, and recurrent pneumonia will be there. And hematologically, there will be anemia in the case of infants, and the children, there will be anemia plus hematemesis. These respiratory symptoms are because respiratory mucosa is very sensitive to acidic pH. Hence, gastric acid exposure leads to wheezing or cough or infection in the case of the gastroesophageal reflux disease. So that is all regarding the symptoms or the clinical features of the GRD. That is, general features are there both in the infants and children. Then GI symptoms, respiratory symptoms, and hematological symptoms are there. The respiratory symptoms are due to this involuntary backflow results in the aspiration of these contents into the trachea, that results in the aspiration pneumonia, and the certain features regarding the respiratory symptoms. Then how will you diagnose or how will you investigate these patients of the GRD? There is no gold standard investigation for the GRD. This is the algorithm for the investigation of the infants. That is when to investigate the infants for the GRD. If the in infants regurgitation is greater than 2 per day or greater than 3 weeks, that is regurgitation happening for the greater than per day or for greater than 3 weeks. That is an suspicion for investigating the infants for the GRD, and also look for the red flag signs. If the red flag signs are present, there is no role of empirical proton pump inhibitors, then we have to further investigate the patient. But if the red flag signs are absent, it may be happy in specters. No investigation should be done, and the reassurance should be given. Modifies feed volume frequency, and optional thickened feeds only cosmetic purpose. We have to give the thickened feeds, and it resolves by the 18 months of age. And if there is no resolving of this regurgitation of these symptoms, there will be we have to further investigate the patient. Then, when will you investigate the GRD in the case of children? That is, GRD symptoms develop. That is, the GAT symptoms, general symptoms, and respiratory symptoms develop, which is suggestive of the GRD. The children should be supplied with the proton pump inhibitors for the 2 to 4 weeks, and also lifestyle modification, weight reduction if obese. And if there is improvement, uh, we have to continue the proton pump inhibitors for 3 months and taper over 3 months. And if there is no improvement, we have to further investigate. And if there is any relapse following this proton pump inhibitor use, we have to further investigate the patient. So that is all regarding the diagnostic evaluation, and which investigations which are used for the is gastroesophageal reflux disease. The usual investigations which are the barium upper gastrointestinal studies. Usually it has no role, but esophageal pH monitoring for the 24 hours, which are important role in the case of investigation of GRD. If the reflex index is greater than 10% in infants, and if the reflex index is greater than 5% in children, that is indicative of the GRD. Then if we have to investigate by the upper GI endoscopy, it is best to diagnose esophagitis, that is due to the continuous influx of the gastric contents at the esophagus, which cause the esophagitis. Though, therefore, to diagnose the esophagitis, we have to go for the upper GI endoscopy. But a normal endoscopy does not rule out the GRD. A term called non-erosive reflux disease is there. So, in the absence of the esophagitis, one cannot rule out the GRD. Indication of the upper GI endoscopy, which are the persistent symptoms despite therapy, that is an indication for the doing upper GI endoscopy. And also we can go for nuclear scintigraphy, that is a milk scan, that is it have the poor sensitivity and specificity, and only indication is for the recurrent pneumonia. If there is a recurrent pneumonia happens, we have to go for the nuclear scintigraphy. And the retention of the radioactivity for the greater than 24 hours, such as the GRT in the case of nuclear scintigraphy. Then we have to go for the multi-channel intraluminal impedance measurement. It is high cost, limited availability, and it is limited implications are there. So the major investigations are the barium upper gastrointestinal studies like barium meal. Then we have esophageal pH monitoring for the 24 hours. Then upper GI endoscopy, nuclear scintigraphy. These are the important investigations which are usually we are doing uh, in the case of the gastroesophageal reflux disease when a patient present with the symptoms sensitive of the gastroesophageal reflux disease. Then about the management, only the gastroesophageal reflux disease needs to be treated, not the gastroesophageal reflux, because gastroesophageal reflux is a physiological phenomenon. It need not to be treated, but the gastroesophageal reflux disease which needs to be treated. So the treatment in infants and also children which are vary. That is GERD in the infants, the counseling is the most important, and the proton pump inhibitors which are not recommended in the case of infants with the GERD. The small frequent feeds and thickening of the feeds with rice, corn, potato, starch decreases number of the regurgitation but does not decrease the acid exposure. So it has only a cosmetic value but no therapeutic value in the case of GERD in the infants. But if a GERD is happening in the children, we have to advise lifestyle modification. Like in the case of obese children, we have to advise for the weight reduction, avoid caffeine, chocolates, and alcohol, and we have to advise the child to sleep in the lateral decubitus with the head and elevation position. So these are the lifestyle modification which have to be advised in the patient with the children with the GID disease. Then we have to go for the drugs or drugs like acid lowering agents, that is proton pump inhibitors and the H2 blockers which are used. Then, but drug of choice is the proton pump inhibitors like lansoprazole 1 to 4 milligram per kilogram per day is given, or omeprazole, pantoprazole. We have to give an alternative to lansoprazole. Then advantage has it has prolonged action, it is safer for the long-term use, and there is no tachyphylaxis will be there. So proton pump inhibitors, which are the drug of choice for the acid lowering agent in the case of the gastroesophageal reflux disease. Then the H2 blockers, this is inferior choice compared to that of the proton pump inhibitors, and we usually uses ranitidine 6 to 8 milligram per kilogram per day, and it is short acting, so that is a disadvantage, and there will be tachyphylaxis if it is H2 blockers is used greater than 6 weeks. Then we also uses barriers like sulfates protecting agents like a sucralfate and antacids as add-on drugs with the proton pump inhibitors in the case of children with the GRD, and prokinetics like a metoclopramide, cisapride, which is usually not recommended, but if indicated, we can be used. But the metoclopramide, which have the extrapyramidal side effects, and the cisapride, which are the cardiac side effects, so they should be kept in mind. Then duration of the medical treatment, which include it needs that is usually the GRD which needs prolonged acid suppression, because we do not we at that time of the drug treatment we do not doing any surgery, so we have to prolong we have to use these drugs for the prolonged acid suppression. So PPI is usually used for the 12 weeks and taper over 3 months, and restarted if relapse is there. A very long PPI treatment is erosive esophagitis is safe. Then surgeries. Then after that only we have to go for surgery. Indication of the surgery is chronic relapse in GRD, refractory to medical management is present, or the surgery, and the surgery of choice is the Nissen's fundoplication. That is. And the fundus of stomach is plicated around the lower esophagus, that is at that area of the lower esophagus sphincter. Therefore, there will be permanent cure from the gastroesophageal reflux disease. So that is all regarding the gastroesophageal reflux disease. That is, we learned about the difference between GR and GRD. That is, gastroesophageal reflux is a physiological condition, and it is usually occurs in the infants. And the gastroesophageal reflux disease is a pathological condition, and symptoms and complication arises from there. And the pathogenesis of this gastroesophageal reflux most commonly due to the any transient lower esophageal sphincter relaxation due to the damage or the any defect happens in the case of the at the level of the lower esophagus sphincter, then about the symptoms and manifestations, about the red flag signs, then the predisposing conditions, common symptoms of GERD like general symptoms, GI symptoms, respiratory symptoms, and hematology symptoms, then diagnostic evaluation both in the infants and the children, about the investigation like upper GI studies, then about the esophageal pH monitoring 24-hour, upper GI endoscopy, nuclear scintigraphy, then management for the both in infants and the children's GRD, gastroesophageal reflux disease have to be treated, but gastroesophageal reflux which do not have need for the any treatment. So these are all the management options like children in case of lifestyle modification, drugs and surgeries and Nielsen's fundoplication. That's all. That is all regarding the gastroesophageal reflux. When an essay is asked, we have to return details about that. So then about the one of the short answers like that of hepatitis B. Usually ask the short questions about the hepatitis B infection. That is, it is a viral hepatitis. The virus, hepatitis B virus is a DNA double-stranded virus. Um, and it has an outer component like hepatitis B surface antigen, and inner core we have the HBeAg, that is a core antigen will be there. And then prevalence is 2 to 5% of people in India which are HBsAg positive. That is the prevalence of the hepatitis B. So then route of transmission, usually it is the hepatitis B infection is a bloodborne infection, and the route of transmission is perinatal transmission will be there from the HBsAg positive mother to the the fetus. That is most important route of transmission is through this perinatal transmission. Then increased risk in mothers who are also HBeAg positive. There will be increased risk chance of transmission to the fetus. And common routes are the in the case of blood transfusion and the unsterile syringes and also drug abusers. We have the chances for the transmission of the hepatitis B and the pathogenesis. There is no direct hepatotoxic injury. Injury by the immune response followed by the fast viral clearance. There will be immune complexes formed due to the infection that will produce the hepatotoxic injury that is not due to any direct effect by the virus. And if an inadequate immune response occurs as a result of the immune complex formation, that is leading to chronic liver disease in the case of the children affected with the hepatitis B. And the stages of the hepatitis B infection are the replicative, that is incubation period for the 50 to 180 days, replicative plus immune clearance stages, that is if there is any symptomatic phase lasts for a month, then integrative, that is viral replication ends at this stage, and viral clearance, that is cured, becomes HBsAg negative. These are the stages for the hepatitis B infection. The children with inadequate immune response do not reach the phase 4, that is viral clearance stage, and it develop chronic hepatitis B infection. Then clinical features of the hepatitis B infection as it is same as that of the hepatitis A virus. That is prodrome stages last for the 2 to 3 weeks. Then a symptomatic phase, which is characterized by the fever, jaundice, that is the yellowish discoloration of the mucous membranes and sclera, abdominal pain and vomiting, which lasts for the 1 month. Is there. Then in the extrahepatic features like arthralgia and papular dermatitis will be there. That is also called the Gianotti-Crosty syndrome. So these are the clinical features. That is prodrome phase, that is last for 2 to 3 weeks. Symptomatic phase, fever, jaundice, abdominal pain, and vomiting will be there for the last for 1 month. Extrahepatic features like arthralgia and papular dermatitis will be there because of the immunological reactions. And the complications of these hepatitis B infections, which are the acute liver failure happens. It can occur as early as 2 to 3 months age in infants of HBsAg positive mothers, and also there will be complications like a chronic hepatitis B. Chronic hepatitis B happens in the case of the children. And what are the investigations we have to confirm the diagnosis of the hepatitis B. In the early phase, we have to go for HBsAg and markers of viral replication, which are positive. That is HBeAg and HBV DNA, which have to be looked for. And anti-HBs antibody, which appears last, that is a marker of the resolving infection. And most children which clear HBsAg by the 6 to 8 months, after 6 months, HBsAg positive, that is labeled as chronic infection. So we have to look for this HBsAg, anti-HBsAg, and HBV DNA, HBeAg for the investigation for the hepatitis B infection. Then These are the stepwise serological diagnosis of the acute hepatitis B. If there is acute infection is there, the hepatitis B virus DNA and HBs AG and HBs AG and HBe AG are present, but the HBs antibodies, HB antibodies, and HBC antibodies are absent. Only the HBV DNA, HBs AG, and HBEG are present in the case of acute infection. But in the case of convalescent stage, the HBs antibodies and all the antibodies like HBs antibodies, HBe antibodies, HBC antibodies are present, but the others are negative. In the case of past infection, only the HBs antibodies and the HBe antibodies are present, others are negative. In the case of immunization, HBs antibodies are present and others are negative. So these are the stepwise serological diagnosis of acute hepatitis B. Then regarding the that is in the treatment, there is no treatment recommended for the hepatitis B. We have a natural cure. We have to only give the supported, that is natural cure by the viral clearance, but we have to give the supported treatment, nor all of drugs like alpha interferon, etc. in the acute hepatitis. And the prevention is by the we have to administer the vaccine, that is hepatitis B vaccine at 0, 1 and 6 months. Then the prevention in the babies born to HBs AG positive mothers, hepatitis B immunoglobulin within 12 hours of birth, 100 to 200 international unit intramuscularly is given in the case of the babies born to HBs AG positive mother. So we can prevent the hepatitis B infection in the fetus. And the hepatitis B vaccine schedule is 0, 1, 2, and 12-month schedule. So these are all about the hepatitis B infection. Thank you.